brief comments, and then we'll go to the first part of the hearing today is about mental hospitals, and then the second and probably longest part of the hearing will be in regards to the governor's proposal when it comes to the Department of Social Services. So with that, we will ask Secretary Dooley. Thank you. We are honored by your presence. We can't wait until you come when we have money.
Oh, boy. You and me both.
May not happen.
Well, maybe not in my lifetime, but perhaps in the lifetime of our children and grandchildren, and I know that's what we're really here about in large part. I appreciate the invitation. I have appreciated the work that we have done together over these first 5 months, and my first message is thank you. Thank you for the very heavy lifting that was done in March. We all together made historic, monumental reductions, particularly in social services, as you well know, of the $12+ billion that was removed. Almost $6 billion of it was from Health and Human Services, and that was very difficult. They were difficult proposals to make, and they were difficult proposals to respond to. And I think we have permanently reset the level of service in many important ways. Regrettably, it's not enough. And we still have a hole to fill in our operating budget, and we have, as the governor has said, a wall of debt. And we are committed to addressing these long-term problems and not ignoring them any further. And your cooperation, assistance, diligence, and partnership has been critical to our making the progress that we've made. The governor's revision clearly remains committed, as I do personally, to the concept of realignment as well as the specific proposal realignment. We believe in also changing the nature of our relationship with the counties to one of partnership and cooperation, of looking to where the services can best be provided, where they're already being provided, and get out of the way and let them run programs that they run, give them the tools, the authority, as well as the funding, and that's why, of course, the extension of the existing taxes is critical to doing that. The money to complete this comes from the existing taxes being extended for that 5-year period, with the modification that the governor proposed to the 2011 income tax surcharge. So that, at the top level, is not new news. In fact, there's little that I have to add. The reductions that you will consider in the changes in May revise to the Health and Human Services, there are a couple of key issues, and I'll speak to that. But for the most part, the really heavy lifting has been done. And while there is an outline for a Plan B included in the May revise, it is completely unconscionable for me to think about. I am not willing. I will go kicking and screaming down the path of an all-cuts budget for the people that are so dependent on a minimum level of service and support. And I have to tell you, I think that's where we are in the cuts that we have already made. And you know them very well. The key issues that are in the May revise that relate to good morning, Senator, to the changes are most significantly with the state hospitals, as you will hear and discuss this morning. And while it is widely anticipated and we're moving toward the enactment of the realignment proposal to move the county-operated mental health and substance abuse programs to the local level, what is left is the state hospitals. And given the conditions in the state hospitals and the extraordinary challenges that they face with the changes in the populations that they've experienced over the last 10 to 12-year period, we made an affirmative decision that it's not going to be the tail wagging the dog. We're not going to let the state hospitals be what's left over. We're affirmatively, actively looking for leadership and to create that department within the budget year and give it the attention, time, and as much resource as we all decide is appropriate together to address the problems in the state hospitals. Another significant issue in the May revise is the 3632 program for mental health services in the schools. Over the years, that has wound itself into such a tight ball of tangled regulations and authorities and funding between the schools and the mental health departments and the welfare departments at the local level that we think it's time to step back and acknowledge it's an education program, the funding is education, and the authority and responsibility needs to be education. And at the local level, the education community will coordinate with the local services available, and we think that is an appropriate and important step to take. And the third main issue that you will address is the proposal to merge Healthy Families with Medi-Cal. And in that program area, there has been a lot of discussion leading up to the May revision about what is known as the bright line of 133% of poverty, that it would make sense to move that into Medi-Cal. And as we completed the analysis and work on that, it became clear to us that we should go the whole distance, and for the same reasons that it made sense to the 133 in preparation for healthcare reform, we should move the whole program and consolidate that program into one program. We are open to your input on how we could do that and the timing for that. Also, I'm very interested in looking at that program and rebranding it so that we're really taking the best of the Healthy Family program and incorporating and making changes in the Medi-Cal program where we need to for the benefit of all the recipients. So it is a proposal that we present humbly and with respect for your participation in that process, but it's one that we think moves us down the path to a simplified system that is better able to be understood by the consumers when we do move to the exchange process for eligibility and enrollment. There are many other aspects that we have, the elimination of CMAQ, the elimination of 43 boards and commissions, many of which are in our area that we think are either outdated or unuseful, or the work that they perform can be done in a less formal and expensive way. I'd be happy to answer any questions. I appreciate the few moments to appear with you and to pledge the support of all of the programs and people within the Health and Human Services Agency to get us to the other side of this chasm and be able to move forward in California as we all must.
Any questions or comments from my colleagues?
Thank you, Senator.
Well, I'd just like to thank you again for coming. I think my one comment would be in the areas you mentioned that we're going to cover soon, but also in other areas like, well, on 3632, as a former mental health commissioner in my county and I'm a county board of supervisors member, I think, and this is probably a good illustration of a lot of at least my personal concerns, which I think so far we've managed fairly well, and that's transition and being thoughtful and still being able to score the savings. Right. So with the continued discussion we have, also with obviously the DD community, but how do we, and in the case of mental health services in schools, trying to develop some kind of transition, and again, still being able to score the savings, but not have school districts run off and terminate existing contracts. So it may be the ones that they should stay with, whether that be with the county or with community-based organizations. And I know that Senator Alquist is, as am I, and Senator Liu, and all of the senators, members of the legislature, about the successful transition for adult day health care. So all of those things, we look forward to continued discussion with the administration so that we're not back here fixing things that we could have been a little more thoughtful about.
I appreciate that, and I've met with all of you, Senator Emerson, Senator Alquist. I appreciate the opportunity to address your concerns, and I really believe that we're all, we want the same goals. We want the most efficient government. We want the most service to the people who need it the most, and we've got to work together to find that balance, and certainly that is my goal.
And I say that, and I know you share this in the spirit of, I don't want to delude people that we're going to stay with the status quo. We can't do that.
That's right. That's not acceptable either.
Right. So I don't want to mislead people
Great.
and have them think, oh, fine, we'll just keep doing what we've always done. Thank you again for coming today.
You're welcome. Thank you for the invitation.
Thank you for all your hard work. It's
Thank
delightful working with you. All right. Now we will move and ask the staff members from the mental health department to come forward. First, we're going to consider this part of the agenda, and as they come forward, we have a vote-only calendar. And for the record, I just want to see if there's consensus on the vote-only calendar. We all support? Okay. For the record, we'll show that that's unanimous. And as we move through these, I just want to remind people what a challenge this is, both emotionally and financially and every other way. And I want to also recognize Senator Evans, who has been working diligently to try to fix the problems, specifically at Napa State Hospital. And for me, I'm always mindful of a constituent, Donna Gross, who lost her life tragically, which is not the only reason we are here today to discuss these things, but certainly is preeminent on a lot of our minds. So in her memory, we will start the meeting and see what it is that we can do to help secure safety, being fiscally mindful at the state hospitals, and also consider the suggestions from the administration. So that, please go ahead. We're going to hear from the department first.
Thank you. Catherine Gaither, Department of Mental Health. Do you want an overview?
Yes, please.
Okay, thank you. So the May revision, I think the Secretary referred to the primary policy proposal, which is the proposal to create a new Department of State Hospitals or Long-Term Care Services that would encompass the hospitals as well as the psychiatric programs. And the administration thinks that this is important because we need to have a department with a singular mission and a singular focus for many of the reasons that you've already alluded to. The hospitals have changed in their patient load over the past decade, and there need to be different staffing ratios, perhaps different leadership, and a stronger centralization and better accountability. We are hoping that we will be able to create a system rather than individual institutions, and we think that that will give us consistency across the entire system and better patient care, better patient safety, as well as employee safety, and better fiscal accountability as well. The other proposals in terms of the state hospitals are related to increased funding and positions for hospital safety, both ground safety teams as well as ground presence teams, and we would like to note that these are important not only for the safety of employees and patients, but also as part of the patient's treatment plans. And it's important that they be able to have access to the grounds as part of their well-being. And other safety measures are a proposal for personal alarms, and the personal alarms will be proposed for Napa as a priority and as a pilot. We want to test this new alarm system and make certain that it's effective, and once we see that it is effective, then we will propose it at additional hospitals. We also have some smaller proposals for training and some other issues, but those are the main primary issues and the priorities of the administration.
Thank you. Any questions? Thanks for the oversight. So we'll start with safety and security at state hospitals. I'll try to remind people in the audience as we move through this, but sometimes I'm a little forgetful. This item is on page 4 of the agenda, the staff report. Yes.
Good morning. Cindy Radavsky from the Department of Mental Health. I'm going to address the questions in the handout, and as always, I appreciate the amount of information and the detail that's in the agenda. So briefly, we were asked to describe the 4 components on the table. As Ms. Gaither mentioned a minute ago, we are asking for a grounds presence team, which would be comprised of psychiatric technicians to be on the grounds with clinical experience during time that patients have translocation and egress access for treatment purposes. This is a program that we've had in place at Patton State Hospital, and it's been very successful over the years. We're also requesting a ground safety team, which would work in collaboration with the grounds presence team, the difference being ground safety would be comprised of hospital police officers that will be roving through the units to provide an increased hospital police presence on the units. It will look for contraband on the grounds and ensuring that there are no illegal activities going on at the time. So we should have a higher degree of oversight on the campus at both Napa, Metro, and the ground safety team would be at Patton State Hospital. These are open campuses, and they're rather large in acreage. The personal alarms, as was mentioned earlier, we'd like to pilot at Napa State Hospital. The department has worked with the California Technology Agency. And, you know, on one hand, we have to have the funding authority to get the pre-authorization, but we kind of need the pre-authorization to get the funding authority. So we've worked hand in hand with them, and they are willing to help us expedite putting these alarms in. We've also worked with the Department of General Services to move that forward as well. So upon enactment of the budget, should this item pass, we should be able to get those alarms in within a 4-month period of time. To go back to Ms. Gaither's earlier comment on the system, knowing we would like to roll the alarms out not only at Napa but at Metropolitan and at Patton, because we have alarms inside the buildings. These alarms will be for the acreage as staff and patients are translocating. We had all 3 hospitals participate in a demonstration from the vendors. We've asked all 3 hospitals to work jointly on business rules so that we're not building a system that's only applicable to one hospital. We need consistency, and the staff have been working very closely with us on this. We've involved the unions, and we asked some ledge staff also to the demonstration. So we've been trying to reach out and include our stakeholders in that development. The last issue on this table is in relation to what we refer to as the Welfare and Institutions Code 7301 process. Right now, that process allows the Department of Mental Health to make a referral to the Department of Corrections for custodial reasons. If we have patients that we have determined are too dangerous to be within the hospital, we can currently make that referral. We've been averaging about 12 to 15 a year. We're noticing, as our population is changing, an increase in the number of those patients, and we've been working with the Department of Corrections on how to further refine the criteria for movement. How would the Department of Mental Health assess these folks, make a determination, transport them, and then, you know, what would happen to them while they're at the Department of Corrections. We know we have some barriers. The Supreme Court decision on Monday morning definitely raises an issue that we will need to continue to work with the Department of Corrections on. And we know there are potentially some Coleman Court issues that will be raised. And I have talked with different folks from NAMI, the National Alliance on Mentally Ill, on their concerns as well. And so we want to make sure whatever is created is a very evidence-based process with, you know, good rationale and logic behind it so that we're not violating anybody's patient's rights as well. So those are some of the things in process right now on this table.
On the last item, I think it's at least important for me, I think you hit on this, that this is objective, evidence-based criteria. Yes. And it's going to be difficult for you, as you said, given the Supreme Court decision, but be interested in having communication from you, how you develop this, just so we have a greater understanding of it. LAO, do you have some comments?
LaShawn Francis, LAO. The department is requesting 78 positions for their ground presence and safety teams. We recommend that you approve these 78 positions, but that you reduce funding by $1.1 million to more accurately reflect the phase-in for this staffing.
Okay, I'm told by our ever dutiful staff of the committee that the department would like to respond to the LAO's comments.
Yes, we would, and I do have a handout for the members. We essentially right now have enough graduates from our psychiatric technician schools to be able to fill all of the psychiatric technician positions for the grounds presence team. For the ground safety teams with the hospital police officers, we currently have 33 in our pipeline in school. They have passed background checks, the majority of them, and we anticipate in July and August to be able to bring those 33 on once they complete the final pieces. We've worked with State Personnel Board on how to expedite the psych evals, and we're working with the hospitals to expedite the background checks that we're responsible for so that we can get those 33 in. So we anticipate a delay of approximately 7 out of the positions we asked for.
Okay, appreciate that. I recognize the delicate balance we're going through that the LA's brought up, but obviously we want to get this done in as a thoughtful and efficient way as possible. So you're suggesting that you're ready to go, and
We believe so, sir.
okay. Any other questions or comments? Then we'll go to public comment. Senator Emerson has a question.
Yes, Mr. Radowski, it appears that you have preliminary approval from the California Technology Agency for going ahead in an agreement on that.
For the alarm system,
With the alarm
yes, sir.
system, yes.
Yes, sir.
Thank you.
Mr. Murch, welcome.
Yes. Mr. Chair, member of the committee, my name is Ken Murch. I'm representing the California Association of Psychiatric Technicians. They provide the nursing services in the Department of Mental Health. Our group is the ones that seems to be the highest percentage that are suffering assaults. As you mentioned, Mr. Chair, we had one of our members that was murdered last October. This proposal that the department is presenting before you is a small step, but it's a needed step. It's something that must be tended to immediately, and we're in total support. The department has been through a really difficult time this year, and particularly in the year 2010, when we saw just a tremendous increase in assaults. To give you some statistics that was provided by the department, in the year 2010, we had 5,133 recorded assaults. 2,200 of these assaults, well, actually 2,226 were on staff. The rest of those assaults were on patients. And this resulted in 1,032 injuries, 1 death. And some of these injuries are temporary. Some of them will be permanent. It will result with these individuals losing their careers and going out on disability. The patient population has changed dramatically in the last 10 years. Out of the approximately 6,300 patients in the department, only 400 of them are civilly committed. So our Department of Mental Health has become an extension of the criminal justice system, and we just can't operate it as we have done in the past. We have a lot of old infrastructure. With regard to the alarm system, the present alarm system at Napa State Hospital is inadequate. It doesn't respond to assaults outside of the units or programs. That's why there's a need to have the grounds patrol. So I know these are difficult financial times for the state and the department, but this is a health and safety issue relative to our members, and we ask your support of the department's recommendations.
Thank you, Mr. Murch.
Mr. Chair and members, I'm Kobe Pizzati with California Statewide Law Enforcement Association. We represent the hospital police officers at all the state mental hospitals. I think it's really important to mention the 7301 process is a critical piece to the overall game plan of making sure the most violent of the violent are not housed in an area where they can prey off the less functioning patients in the state mental hospital system. We want to make sure that the people that are just way too hard to handle are in the appropriate setting for that. So in that sense, I believe the 7301 process is a critical component to helping the system get back on the right track of, protecting patients and making sure they get the treatment. Secondarily, the proposal to add additional hospital police and psych techs we fully support. However, I would just like to add a brief little anecdote. I think the staffing amounts is pretty inadequate, considering in 2007 you had 76 hospital police officers at Napa State Hospital work 72,000 hours of overtime. I mean, that is an astonishing amount of overtime. Currently, you have 74 hospital police officers working at Napa State Hospital. They're working the same amount of overtime. You have fewer. Part of our problem that we're seeing is the state mental hospitals where you have a close-by prison where the starting pay is $75,000 a year. Your top step for a hospital police officer is roughly $50,000 a year. So you see most of the candidates go towards the prisons. So we do appreciate the positions, and we think, yes, this is a good first step. We would like to go further in trying to make the facilities more secure. But we absolutely believe that this is the right step in the right direction.
Thank you, Kobe. Other witnesses?
Margaret. They told me to flick the switches and it would work. I'm Margaret Johnson with Disability Rights California. We represent people with disabilities. I just want to say that we certainly want to make sure that the hospitals are secure and safe for the residents and the patients at the hospitals. In addition, we just want to make sure also that there is some focus and effort to improve treatment modalities so that folks don't escalate and you don't have to put in so much security. So thank you very much.
Appreciate all your comments. Any other public comment? The motion is to adopt the May revision. We do want to have ongoing dialogue, and particularly given all of the issues, as you said, around the Supreme Court decision. This is going to be very complex, and I think what we would all like to be assured is that California's still, in spite of the fiscal conditions and challenges, we're doing everything possible to assure everyone's safety at these facilities.
If I may, I have an additional handout that you might be interested in on all the efforts that have been made to date. It's an update from our last hearing.
We would appreciate that.
Okay.
Anything you do in terms of sort of looking back at the root cause of all of these incidents, but particularly the serious ones, I think is helpful for us to understand, and also to develop some level of confidence that you are doing everything professionally to correct situations like this. So just like at any hospital facility, but particularly at these. Thank you.
Absolutely.
So the motion was to accept the May revision, and for the record, is that unanimous? Okay, thank you. That'll take us to item number 2. This is on page 7 of the staff report. This is in regards to Stockton Healthcare Facility, pre-activation functions, Department of Finance. Go ahead.
Okay. Essentially, this proposal is coming from a January 2010 court order from the Coleman Court related to the long-term bed planning that we provided at the request of both courts, both the Plata Court and the Coleman Court. The proposal now is for the receiver to build approximately 1,500 beds within the Stockton community, and the Department of Mental Health has been tasked with operating 480 of those beds. So the request is for 8 staff members that would comprise our activation team to get policies, procedures, licensure in place, and start the activation of the beds we're responsible for. We are coordinating very closely, thank you, with the receiver and the CDCR mental health program to get this program up and running.
Thank you. Elio, do you have anything?
We have no issues.
Okay. Any questions or comments? Any public comment? The recommendation is to approve the May revision. No public comment, so the motion is to approve the request. Any dissent? Record will show that that's unanimous. That will take us to item number 3, and this is the proposed restructure of the Department of Mental Health and state hospitals. This is on page 8 of the staff report.
Thank you. As we stated earlier, we are proposing to create a new Department of State Hospitals. We anticipate that there will be a proposal in the January budget, and we do not yet know the process that we'll use. So we're looking at the processes, whether it should be a governor's reorganization plan or separate legislation, and that's something that we will be looking at and discussing with community members, stakeholders, the legislature, as well as anyone who can help us determine the best way to do that. We think that this is critically important for the reasons we stated earlier, and we will be attempting to, look for leadership. I think that Secretary Dooley is already considering this, and we know that one of the things that we would like to do is professionalize our institutions more like hospitals. I'm not trying to say that they're not being run as hospitals now, but we know that in the hospital industry there are modern best practices that we need to be looking at, and we want to incorporate those that are appropriate for our centers and programs into our centers and programs. We know that the treatment needs are different. We know that the patients are different, and there are many changes that are going to have to occur in these institutions. Thus, we need a strong team. We need a strong centralization. We have already begun on some of the fiscal issues, and I have a handout that may be helpful. One of the things that we have noticed is that because the hospitals operate in statute as independent institutions, they're able to simply pay bills and make purchases without approval from central headquarters. And given fiscal times that we are going through now, this is not a good fiscal practice. So we are administratively implementing new steps to hold our executive directors more accountable on a more frequent basis. We intend to do more conversations about their progress on their expenditures versus their budget. We want to standardize purchases and standardize everything related to the hospitals, and we know that there are measures that we can take to improve, for instance, prescription purchasing, everything medical, as well as the normal operations of the institutions. So those are all things that we can begin now, but we know that many of the larger changes will take longer, and the beginning of that will be the creation of the hospital. I think the administration is committed to working with all of you on the best way to do that and how it should look. We will, of course, seek your input, and I think, as Secretary Dooley said, we're looking for partners in this effort. We're all in this together, and we really want to make this work.
I think the last question is important in that our staff has asked, and I understand that this is sort of evolution, but how we stay connected to the process, I think, is important, both the Fiscal Committee and the Policy Committee. So I would ask you to respond to that. But what I'm particularly interested in is knowing you're overwhelmed with a lot of work, but some won't hold you strictly to it, some timeline for implementation, sort of looking at key thresholds there. And I think that I sense that part of the challenge is, as you alluded to, allowing the different facilities to be autonomous but still keeping some control. So given that you want to have best practices in the healing arts, and as we constantly evolve in our understanding of mental health issues, but at the same time aren't driven by just the need for bureaucracy, but actual good business practices. So you sort of alluded to that, and I'm particularly interested in how we do that and we evolve. And again, we're going to have to do this in a world that's very different, not just financially, but again, as was said, the timing of the Supreme Court decision, and we're going to have lots of individuals moving in and out of these institutions. And to the degree that we can avoid mistakes, it's going to be really determinative, I think, politically on how we respond to changing these facilities. So I wonder if you could just talk a little bit about the last question, keeping us involved, getting a timeline for us, and again, we'll want to include the Policy Committee in those discussions as well, because we know that there are a lot of bills working through both houses.
Yes, thank you. We don't have a timeline yet, other than we anticipate something in the governor's proposal in January. I I can personally commit that we will work with the staff and any members that are interested, with both houses, both parties. We need the help, frankly. I think this is a big job. It's a complex job, and we are reaching out to stakeholders and community groups as well. I don't know yet what form all of that input will take. I don't know if we will have, large meetings with public input or smaller meetings where people can feel a little freer to express their concerns and issues and needs. But I think we are absolutely committed. And as soon as we have a timeline, we will share it, of course. I think the Secretary is really very much about collaboration, openness, and transparency, and I think that's what she wants us to do as well, and that's my personal commitment.
Well, I'll certainly engage with the Secretary, and I'm sure my colleagues will as well, to try to get, because I want to avoid, we want to have the appropriate level of oversight from the legislature, but I certainly want to avoid sort of the gotcha mentality. We want to work with you as partners
Absolutely.
to make sure that this is seamless. The best thing that could happen is that we're not involved in the sense of coming back after some unfortunate incident. And I don't think we can minimize, at least in my mind's eye, the danger to not getting this right, that there are going to be struggles, there are going to be incidents, but to the degree that we can sort of understand that those are going to happen and do everything humanly possible to avoid them and the communication to be robust, I think is really important. So understand you've got a lot on your plate, as do we, but
Yes,
this is really
yes.
important.
Thank you very much. I think that we look forward to the partnership, and we share your goal of getting this right the first time, or at least as right as we can together.
Well, there are people's lives at risk,
Yes.
obviously. So, Senator Alquist.
Thank you. You have a lot on your plate, and we appreciate what you are doing. 3 different sets of brief comments. On purchasing, so all the hospitals act independently. Is there any cap on what if they go above a certain cap, that there's review by a higher level, or how does that's my first question on the purchasing.
There is a threshold where we look. They provide a monthly report up to my office on their projections and what they're spending. There are certain things that they do purchase locally because we participate in the small business requirements, and we do like to support our local community. So there are certain things that we have to purchase as a group, certain things that we purchase independently. But we meet frequently, and one of the new things we did add was a new meeting with our accounting from headquarters as well as our budgets from headquarters, and we've stepped up those meetings and oversight discussions.
So there's no cap?
There's no cap.
Okay. What I would suggest is you really look at that. I've made this suggestion in other areas, other departments, but it seems to me it would be easier if everyone understood what a reasonable cap is, whatever that amount is that you decide. And perhaps next time you come before us, our committee, you could share with us what you've done in that area. Second comment, understand that you're going to have a timeline in January for what needs to occur by the following July, or that's the plan. And what I would suggest is that I'm not going to ask you questions now on what you're going to do, but I believe the timeline in January that at some way or another you'll be presenting to us needs to have a whole lot of detail, because it isn't very long from January to July. And then my last comment on the IT, because I've always been very interested in IT, it says as centralization of IT has begun, but more needs to be done. And I think that's centralization of IT is going to be key in this new formulation of state, what the state hospitals will look like, how they will serve people. So, can you just say 2 or 3 things, examples of what you are doing in IT that will help assure that whatever you do the following January will be made easier because of the IT implementation you've done.
Yes, ma'am, we can address that. Under the previous OCIO, we were required to centralize and move the IT staff that currently work at the hospitals under the CIO within the department. So the CIO works very, very closely with us. What we did to start that movement was we reactivated what we call our Hospital Automation Committee. And we have one of our hospital administrators that is the liaison with our CIO, and then the IT managers. They're at that meeting. They review any purchases. We look for any efficiencies in purchases, because if we need for one, can we get a better deal with economy of scale for all the hospitals? We're looking at any software or software development. If we need a program, rather than just letting the hospitals now go out and grow something as they historically have, we're trying to coordinate the platforms, and if we need it at one, we obviously need it elsewhere, so let's build it to fit the entire system. So we've put more of that type of oversight in place, and we've been able to get our IT folks in headquarters out to do problem solving, and they're more linked in help desk answers in any kind of breakdowns or infrastructure issues, and development of projects as they're moving forward.
I'm hopeful that with the beginning of the new year that we will be able to sit down together again, and that you will be able to share some philosophies as to how the IT system can be implemented across the state for the state hospitals, and that the different hospitals are using the same system. And there's many, many reasons for it to be done with the uniform system. And so I hope you will consider that, and when you come back and speak with us, share with us what you're doing in this area. Thank you.
Happy to. Thank you, Senator.
Thank you. Senator Emerson.
Thank you. Since the population of the state hospitals has changed so dramatically in recent years, have you considered moving the administration of the state hospital system into the Department of Corrections and Rehabilitations rather than having a whole separate department? Or is that something you've not looked at this stage?
It's not something that we are currently exploring, and I think it would be complex given all of the various court orders that are actually ordering mental health treatment in our institutions rather than in corrections institutions. So it would require collaboration with a number of entities to make a change like that.
Okay. Thank you.
Thank you. Any public comment on this item? This is informational. This is we're starting off on a long, or a short, but probably long and thoughtful, hopeful journey here. Any public comment? Seeing no one. Again, this is just informational, so thank you. Look forward to working with you and for a successful endeavor and change. And before you leave, obviously, on some of the timeline too, just I know you're very good at this, but dealing with the stakeholders, so people like NAMI, people like our employee groups, and obviously our local partners in the county and public safety. I know that'll be part of the timeline. Thank you. We're now going to transition to the second part of our hearing, the Department of Social Services, so we'll just take about a 5-minute break while everybody sort of rearranges here. Vote only first. Do you have that list? Well, while we look for where I misplaced the list, let me just say we are going to move through all of these items as quickly as possible. The original idea was to try to do this in just a couple hours. We will try to maintain that. Since Jen's found where I misplaced my paperwork, let's go to the vote only on this part of the agenda. And it's my understanding, and I'll be more than willing to be stand corrected, but on page 2 of the vote only agenda, we're told that that is unanimous, 3-0. And then on page 3, on issues 1, 2, 3, 5, 6, 7, 11, for the record, that would be unanimous. And then on issues 4, 8, 9, 12, Senator Emerson is a no, so the record will show on those items, 4, 8, 9, and 12, that the vote is 2-1. Is that correct? Okay. And we'll move to our
If I could address the chair, I'm sorry.
Sure.
Jake Kapoor with the Department of Finance.
You just got to jump in here. Good job.
Just wanted to point out that the, understanding the, significant fiscal crisis that we're in right now, the positions requested, resources requested for the Department of Social Services would address various federal and state mandates. Without these resources, these mandates will either go unmet or the department would have to redirect resources from other areas, and therefore there would be consequences there. So just wanted to get on record.
Thank you, Mr. Kapoor. And that'll take us to our first item. This is issue 1. This is the proposed elimination by the administration of 3 health and related policy commissions. We'll ask the appropriate staff to come forward from the Department of Finance. LAO is in place. And this is on, the first item is on page 25 and 26 of the staff report. And as always, we'll hear from the department, then we'll hear from the LAO, any questions from my colleagues, and then we'll go to public testimony on each issue item. I did neglect to mention that we pulled item number 10 on the vote-only calendar. We'll actually hear that at the end because it was indicated to us that there were some members of the public who wanted to comment on that. So we'll go in the agenda order item until we get to that one, and then we'll take that up last. Welcome.
Good morning, Mr. Chairman and committee members. I am David Carlisle, Director of the Office of Statewide Health Plan Development, and with me is Stephanie Clendenin, our Acting Chief Deputy Director. The committee has 2 questions for us. The first is to describe the role of each of the commissions proposed for elimination and functions that the office will take over if the eliminations are approved. The first commission is the California Health Policy and Data Advisory Commission. The second is the California Healthcare Workforce Policy Commission, and the third is the Rural Health Policy Council. The Data Advisory Commission, CHIPDAC, was established in 1986, has 13 members, 9 of which are appointed by the governor. This commission, as are the others, are all advisory to the office. In the case of the CHIPDAC, its role is to advise the office and the director on the collection and reporting of healthcare information, to review and make recommendations regarding regulations, and to hear appeals by healthcare facilities that are subject to fines for missing reporting deadlines. The Workforce Policy Commission essentially advises the department on the function and funding of the Sahm Brown program that supports the training of family practitioners, nurse practitioners, physician assistants, and registered nurses in the state of California. And then finally, the Rural Health Policy Council serves as a medium for interchange and communication between California's rural constituents and the directors of 6 Health and Human Services Agency departments, OSHPD, Alcohol and Drug Programs, EMSA, Department of Mental Health, the Mr. MIB program, and the Department of Healthcare Services. The reason the governors May revise is proposing the elimination of these bodies is entirely consistent with the governor's effort to streamline government and to focus on core functions in order to meet the public's needs. The department will continue to address these functions For example, in the case of the CHIP deck, we will continue to solicit stakeholder input on the application of policy on our healthcare data work area. We will continue to hear appeals through department function, which is one of the mechanisms that is established statutorily for this process. In the case of the Workforce Policy Commission, we will continue to operate the Saul Brown program. We'll continue to evaluate applicants using statutory guidelines, and we'll continue to award the roughly $6.7 million in support of the program. And then finally, in the case of the Rural Health Policy Council, we will continue to interact with rural constituents as we have done so in the past. We will be available to operate a funding program if funds are available in support of rural constituents. And the second question that you have before us is how will the office ensure that the diversity of voices in support of each of these bodies will continue to be heard. And I would say that the department will continue our history of active interaction and exchange with the various constituents involved. For example, in our healthcare data advisory area, we work with the California Health Information Association. We work with the Health Access Consumers Union. We have active dialogue and interchange with each of these entities in this area already. In the case of the Workforce Policy Commission, we're very active with a number of bodies, including our own Health Professions Education Foundation, the California Workforce Consortium, the California Workforce Alliance, our Workforce Development Council that is implementing healthcare reform presently. We will continue those roles. And certainly we will remain active and attend meetings of the California Rural Health Association and engage in dialogue with the association after the elimination of the Rural Health Policy Council. Thank you.
Thank you. Anything from the LAO?
Sean Martin with the Legislative Analyst's Office. We don't have any issues to raise with this proposal.
Thank you. Any questions or comments from committee members? We appreciate your comments about outreach. We certainly want to stay engaged to make sure that all the constituent groups still feel like they're having input. And, of course, we appreciate all the people, commissioners and board members who have been involved. But the motion is to accept in these difficult times the administration's recommendation. So is there any public comment on these items? Seeing no one, so the motion is to approve the trailer bill language for the May revision. Is there any dissent? Oh, okay. Thank you.
Thank you, Mr. Chairman, committee members.
Thank you for being with us today. That'll take us to the Department of Alcohol and Drug Programs, and issue number one in this area is transfer of drug Medi-Cal to the Department of Healthcare Services. And this is on pages 27 and 28 of the staff report. Good morning. Who would like to begin?
Good morning, Mr. Chair and members. Michael Cunningham, Acting Director, Department of Alcohol and Drug Programs.
Welcome, Michael.
Thank you. Consistent with realignment, the state has assessed what state functions can be realigned to the counties, what can be eliminated as being no longer necessary, and what functions the state will retain. The goal has been to provide as much flexibility as possible while retaining the minimum state functions necessary for the realigned services. Those state-level functions for the drug Medi-Cal program will be transferred and to the Department of Healthcare Services effective June 30th of 2012. You have asked for a description of the functions in which are proposed to be transferred. And there are 10 functions of which will be transferred, and there are 2 functions of which will be retained within the Department of Alcohol and Drug Programs. The functions which will be transferred include the development of the drug Medi-Cal programmatic standards. And those are the standards of which providers are required to meet in order to provide services under the drug Medi-Cal program. Secondly, is the function of the administration of the drug Medi-Cal portion of the state Medicaid plan. and that includes all of the legal, the regulatory, and the policy analysis for any amendments on the state Medicaid plan. Thirdly is the establishment of the rates of which providers are required to not exceed as far as the services in which are provided under this program. And that includes a rate-setting methodology and with input, looking at all the cost report data, and then determining what is the rates in which will be set on an annual basis. Fourthly is the management of the drug Medi-Cal claims, and that is ensured and that all claims are submitted accurately, timely, and are appropriately adjudicated and through the short dole Medi-Cal system, which is currently operated by healthcare services. It also includes the cost report settlement process. In the cost report settlement process, we have the accountability for the expenditure of all the federal and state funds and looking at the year-end cost report data, and which is submitted by counties as well as providers. 6 is to maintain the data collection as well as the IT system integrity. And that ensures that the IT systems in which are necessary to support the program as well as its business functions are developed, they're operated, as well as maintained. 7th is conducting the financial audits and to ensure that all of the expenditures of the counties and providers are audited and ensuring that the providers are in compliance with all the applicable laws, the regs, and the guidelines which are associated with the drug Medi-Cal program. Now, another function is to conduct the complaint investigations, and that is to investigate all the drug Medi-Cal complaints to determine if there has been any misrepresentation of fact or of a potential fraud. We will also, a function which will also move is managing the appeals process as well as hearings, and when there are grievances and complaints arising from audit findings, that there will be both informal as well as formal hearings, and which may arise. And lastly is to conduct the post-service and post-payment provider reviews. And these reviews are to ensure compliance and with standards of care and other requirements, and ensure compliance and with the regulations, as well as initiate recovery of payment when those requirements have not been met. So those are the 10 functions of which will be transferred over to the Department of Healthcare Services. You would also ask what functions are to be retained and by our department. And there are 2 of them. One is that our department currently conducts a certification of the drug Medi-Cal providers that includes any new providers as well as renewals. It also includes any time a provider wants to relocate, establish any satellite offices, as well as any time there is a change of ownership. And secondly, that our department is currently responsible for the narcotic treatment program services, and that includes the review and approval of applications, and for the NTP's licensure renewal, as well as any time there is a slot increase or a slot decrease. So those are the functions of which are to be retained and by the Department of Alcohol and Drug Programs.
Thank you, Mr. Cunningham. Before we go to the next speaker, I just want to remind people that This item is just the transfer of drug Medi-Cal, and it's not about the governor's suggestion that he proposes to eliminate the department. Mr. Cunningham will still be with us for a while, and that will be discussed in this committee after the January budget is proposed to us. So not to confuse the items, although obviously it's important and we want to engage in that discussion as soon as possible, but not here today. So I just want to remind people of that. Go ahead.
Okay. The next question you asked is, what is the timeline? Our intention is we have already started to meet and to work with the Department of Health Care Services, and that transition activities will take place and during FY 11-12, and that the effective date of the transfer will be June 30th of 2012. And the third is, you would ask, what are the arguments in favor of the proposed transfer? This transfer, it will consolidate all of the drug Medi-Cal services under the single state entity, with the overall responsibility for the implementation of the federally subsidized health programs under Medi-Cal, thus creating efficiencies for the state government, counties, as well as providers. Secondly, the transfer will establish the potential for a unified health program implementation as well as a coordination of services. You would also ask what concerns have been raised. Three of which have been mentioned include that it could result in minimizing the importance of substance use disorders services and treatment and problems. Secondly, that there could be difficulty in integrating the ADP systems with healthcare services. And thirdly, that there could be a lack of coordination with services provided by other systems such as corrections, social services, as well as local government. And lastly, you would ask, what are department plans for effectuating a smooth transfer? Our department, as I mentioned previously, has already been working with the Department of Health Care Services, and we will continue and to work in concert and with PHCSD counties as well as providers to, in fact, to coordinate all of the programmatic implementation necessary by this transfer. It is our intent to establish a work plan and schedule and identify what are the key milestones and work through the transition period all throughout the fiscal year leading up and to the date of the transfer of June 30th, 2012.
Thank you, Mr. Cunningham. Department of Health Services, do you have comments?
Vanessa Baird.
Ms. Baird.
Vanessa Baird, Department of Health Care Services. I'd like to add some additional comments to Mr. Cunningham's, especially with regard to question number 3 about the plans for effectuating a smooth transfer. We look at that from two perspectives. The one that is mentioned specifically in the agenda is about interruptions, preventing interruptions in services to clients, and then there's an administrative component as well. The Department of Alcohol and Drug Programs have been a really good business partner with us in the Medi-Cal program. They have experienced people who are committed to the mission and have done a lot of work in building up good programs and good relationships. It is the department's intention to make sure that we preserve those relationships and the programs that have been put in place, and only when we're looking for opportunities to improve are we looking for changes. So it is very important to us that as we shift programs over to DHCS, that we do so in partnership with alcohol and drug programs so that there is not a disruption at the local level. Clearly that means that we are, at the risk of sounding like a poacher, very interested in the people in Mr. Cunningham's department who have that expertise and have that commitment to this program, and bringing them over with us and bringing them as into part of our department and our culture. the trailer bill language that has been put forward, which is a major first step, you will see that it takes the authorities that currently exist and move them over. We're not proposing new programs. We're not proposing new delivery systems. We want to preserve all that is good that is currently in place today. My Chief Deputy Director, Karen Johnson, can address some of the administrative issues.
Good morning. Karen Johnson, Chief Deputy Director. To ensure a smooth transition, we would work closely with the alcohol and drug programs. We would develop a master transition implementation plan. We would have several components to that plan. Of course, we would have a human resources plan and information technology plan. We'd also have a facility and space planning component, labor relations plan, as well as, the auditing and investigation, as well as the legal transition plan. So we would work closely with developing a timeline. We would be developing a communication plan, making sure that we are strong in our communications about what is happening, when it's going to be happening, and communicating with our stakeholders, as well as the impacted employees.
Okay, we would be interested in seeing that timeline be a theme throughout these hearings when we're going to make big changes. Just the Department of Finance, as we go through this, and I don't want to do what I just tried to avoid having all of us do, but since this is a big part of the governor's ultimate proposal, I think it's important, at least for me, to understand cost savings and improving the delivery of services. So when you're doing your plan, at least for me, I would like to see both. And I know it's not an exact science, but I think the question has to be asked. And I feel strongly about this. I think there's a wonderful opportunity here, along with realignment, to actually have delivery of service improved if we do it right. But if it's just driven, and it should be driven by our fiscal needs, obviously, but it shouldn't only be driven by that. We should be looking at, because if we don't do the delivery of services and consider that, as I mentioned to the Secretary, we'll be back here for multiple years trying to fix it, not just here, but in the Department of Corrections, in the education field as well. So do you have any comments, Finance, or just at least let me hear a commitment that we're going to work together on this to make sure that we have measurements from the Department on delivery of services, including our partners in local government?
We're definitely open to work with all the interested parties in finding all the efficiencies that are available.
Well said. I like to put words in people's mouths and then get a commitment. LAO?
Sean Martin with the Legislative Analyst's Office. We think this proposal has merit. However, the details are lacking. There are many benefits that could be realized. For example, we could eliminate administrative redundancies that currently exist, and that could also result in better coordination of services between the physical health care that's provided under the Medi-Cal program and the behavioral health care that's provided under the Drug Medi-Cal program. But the details are lacking. We haven't seen a detailed plan in writing on how the administration plans to transition the program from the Department of Alcohol and Drug Programs to the Department of Healthcare Services. We've heard them talk about it. And we think the legislature should seek more information. They should request information regarding what the timeline for the transition will be, how the Department of Healthcare Services would ultimately be reorganized, because we assume that there would be positions transitioned from the Department of Alcohol and Drug Programs to the Department of Healthcare Services. We'd like to see organization charts that demonstrate that. Also, we'd like to see what efficiencies can be achieved through this transfer, and by that we mean administrative efficiencies. Can we eliminate redundant steps that currently exist? Also, what would be the fiscal impact on state and counties if we are eliminating administrative redundancies? It stands to reason there could be some savings there, and we'd like to see a plan that allows us to identify those savings. And finally, how would DHCS ensure coordination with the counties? We've heard them commit to that, but we haven't seen a plan in writing that explains how they're going to do that. So in addition to that, this does raise some policy issues regarding access to care, quality of care, continuity of care. All of these could potentially be affected by what the administration is proposing, and we think that this should be viewed in the context of federal health care reform. We're going to be implementing the exchange in 2014. are there any implications in this transfer for coordination with the future healthcare exchange? So based on those concerns, we're recommending that this be referred to Policy Committee. And we haven't discussed it here today, but the administration is proposing budget bill language in the Department of Healthcare Services that would give the Department of Healthcare Services broad authority to implement this transfer. We're recommending that you reject that, and because it does give too broad of an authority, but we're certainly willing to work with them to craft budget bill language that it requires more specific information if the legislature does wish to go forward with adopting that budget bill language.
I appreciate that, Mr. Martin, and I think that as we go through this, we're going to ask for some of that, and there'll be some of this, and if we don't reject, and there's more as we go through this proposals, but we certainly would anticipate additional trailer language in the budget bills if we don't just reject them, because clearly we want to be very engaged in this transfer and make it work. Any other questions or comments? Senator Elquist agrees. All right, we have some public comment on this.
Good morning.
Good morning.
Al Sinella, President, California Association of Alcohol and Drug Program Executives. Excuse me. I appreciate your comments that the issue of getting rid of the department is off the agenda, and I won't go into my comments about that. The committee has received written communication from the association already. I will be brief. On the issue of the transfer of drug Medi-Cal to health services, the association supports the proposal. We heard the secretary say earlier that, we can't keep doing what we've been doing, and I couldn't agree more. The association couldn't agree more. We can't keep doing what we've been doing. And we think that this proposal provides an opportunity to do some things very differently and very much better than what we've been able to do to date. In addition to efficiencies and savings, and we're not sure that any of this gets around the point of savings, that it brings about any real dollar savings, but we do think that it can bring about a lot of efficiencies and probably some savings with that. There are a lot of California regulations on top of some of the drug Medi-Cal services that are on top of federal regulations that we think are highly inefficient. And a good look at those and perhaps the removal of many of those state regulations, just living with the federal regulations, is probably both a cost-saving and an efficiency act that could be taken. Just one area. Some of the certification issues with regard to drug Medi-Cal could be streamlined and made much more efficient and perhaps save some costs as well. There are a number of other things like this that we as stakeholders, I think, can bring to the table as part of that process. We think that it's absolutely necessary that the plans that were discussed be developed hand in hand with the stakeholders, with the folks that are providing these services up and down the state. Not a brief meeting, not a submit your comments, but ongoing dialogue, establishment of a work group that we're there each time with the departments with this transfer effort, making sure that it's done correctly and to everybody's interests. Finally, I would say that one of the most important things from our perspective, something that we have advocated for since the efforts to renew the 1115 waiver started, is the inclusion of substance use disorder services as a required benefit under that waiver. We believe that this transfer is an opportunity to revisit that issue and to perhaps put these drug Medi-Cal services within the 1115 waiver and use it as a demonstration project, a pilot project, to show how these services can be integrated with the rest of the healthcare world between now and when 2014 comes. If we don't begin that process now and just simply transfer it over to health services and carry on as usual under a new department and wait for 2014 to do that integration, we're going to be way, way behind the eight ball. Thank you.
Thank you, Mr. Sinella, and I certainly agree with your comments about engagement in the process, so we would expect that, and we expect that as part of the plan and the timeline. Next witnesses.
Good morning. I'm Dr. Jason Kletter. I'm employed by Bay Area Addiction Research and Treatment, and I represent the California Opioid Maintenance Providers, the statewide provider group representing 140 methadone treatment programs around the state that serves about 35,000 patients. And I'm here to say that our group also supports the transfer of drug Medi-Cal services to the Department of Healthcare Services for all of the reasons that Mr. Cunningham and Mr. Sinella have articulated. However, as the gentleman from the LAO said, there's lots of unknowns still in this plan, and we are neutral on the larger realignment plan as a result of the many unknowns. However, I think a few of the key issues that we want to be sure are considered in the transfer of this piece of realignment are things that Al said, but also importantly that the Department of Healthcare Services or whomever it is that has responsibility for this at the state level continues to have the ability to directly contract with providers in those counties where the county decides they don't want to contract with providers. Methadone carries a substantial stigma with it, and there's lots of counties who have decided they don't want that service, and so they don't provide it. And because of that, there was a lawsuit in 1993, and the state took on those contracts. So direct contracts is a critical piece that needs to be retained at the state level. Statewide rate setting needs to be retained at the state level. We can't have a patchwork of rate setting from county to county. It makes it difficult for multi-county providers. It makes it difficult for the state to reconcile those bills. And so statewide rate setting is important. It's also important that there be a statewide program for establishing program standards and rules and regulations, and not allow counties to say, okay, we'll do this program, however, we're going to pile on onerous rules and requirements that are going to make it really difficult for a program to operate. So I also want to echo Mr. Sinella's comments that through this process, we hope that the Department of Healthcare Services will work closely with providers to help ensure that these considerations are taken into account in the transfer of these responsibilities, and that there continue to be a support for drug treatment services. And I thank you for your time.
Thank you, Doctor. Thank you for your work. We can take more than one witness at once. Don, if you want to come up and grab the seat, yeah, that would be great.
Chair, members, Robert Harris on behalf of California Society of Addiction Medicine. We think this is a wonderful opportunity to finally get rid of the false dividing line between mind and body. We're already beginning conversations with our colleagues in the mental health community to figure out a way that when all these transfers and changes take place, that this doesn't get lost, that substance abuse treatment and mental health treatment doesn't get lost, that the LAO was correct, that we see one of the biggest opportunities coming is in what happens in the benefits under the exchange, that we're convening a small meeting that we hope to expand and include the entire treatment community in both perspectives, and we're starting on June 9th. We look forward to working with the departments to make this happen and make it really function in a way that benefits people who right now don't get good benefits because we treat the mind and the body as something separate when they are integrated. And we look forward to moving forward on this. Thank you so much.
Thank you. We look forward to working with you and the affected departments. Anyone else on this particular item? Wasn't trying to scare witnesses away. Okay. Any comments or questions from committee members? The recommendation is to approve, and this would be the motion, approve the transfer of responsibility for administrating drug Medi-Cal from ADP to the Department of Health Care Services, and correspondingly to adopt placeholder trailer bill language. And of course, we're going to have an ongoing discussion, so that's acknowledged in the motion as well. Is there any dissent? All right. Thank you. That will take us to the Department of Rehabilitation, issue number 1, and it's the only item in this department is the proposed change to the appeals process. Try to go through this quickly. And this is on page 29 of the staff packet. And then after that, this obviously will go to social services and work through their issues. And as soon as the department's ready, we'll go ahead and begin. Welcome.
Good morning. Tony Sauer, the Director of the Department of Rehabilitation. Thank you for having us here today. So I'll just open up by describing our process briefly. The Rehabilitation Appeals Board consists of 7 members appointed by the governor. Members serve on a term of 4 years and are subject to Senate confirmation. The Rehab Appeals Board hears appeals by consumers and applicants for services who wish to contest a denial of eligibility and by existing consumers who are not satisfied with the services being provided to them. Our department provides vocational rehabilitation services to approximately 115,000 Californians with disabilities annually. In federal fiscal year 2010, over 10,700 consumers achieved successful employment outcomes. During that same period of time, 39 requests for appeals were resolved. The administration is proposing to eliminate the appeals board and change the mechanism used to handle appeals by applicants or consumers to an impartial hearing officer. This process will improve the process and create a savings that will be reinvested into consumer services. So you had 2 questions for us. The first question is to describe the appeal decision-making process as they exist today and how they would differ in the proposal. Currently, the applicant and consumers of the department submit a written request for hearing to the Rehabilitation Appeals Board. These issues are heard by gubernatorial appointees, and decisions are rendered by the board within 45 days. Under the proposed process, the consumer will submit a written request to a fair hearing coordinator the same way. The issues will then be heard by an impartial hearing officer, and decisions will be rendered within 30 days, which is 15 days less. California is one of only 2 states, Vermont being the other, that continues to utilize a Rehabilitation Appeals Board. Other states have moved to either an impartial hearing officer typically or the ALJs. So that's how the process will change. Essentially, the same issues will be presented going forward, the same process, but instead of convening a board trying to get a quorum, we will have a hearing officer do the hearings. Okay?
Yep.
The second question you had, what are the administration's plans to ensure the accessibility of the appeals process to consumers of the department services? The consumers will still have the same level of access to the appeals process. The impartial hearing officer will have specific knowledge and expertise in statute and regulations and will be able to effectively and efficiently sort through the complex legal issues. Upon completion of the hearings, the impartial hearing officer will render their decision in 30 days instead of the 45 currently. The documentation record will be completed in a format that hopefully will better meet the consumer's need if they decide to go forward with this to the Superior Court, and that's their choice. Additionally, we have 3 other mechanisms that are more informal before it goes to the appeal process. We have what's called administrative review. If a consumer doesn't feel their needs are met, one of our 14 district administrators around the state will meet with the consumer and the counselor and try to resolve the issue at a low level. We have our client assistance program, which is similar to an ombudsman program that's statewide to try to resolve those issues. And then finally, we have a mediation agreement where we will help with, mediate consumer problems. So they can do any of those 3 or all 3 along with the appeal process at the same time. So I feel as though, as a former consumer of the department, we do reach out to meet the needs when there's issues are not being resolved.
Thank you. LAO?
Christine Fry, LAO. We have no issues with the proposal.
Okay. Any questions or comments? Well, I appreciate your endeavors, and of course the one concern that I have, and I think it's shared by all of us, is that California has been really good about the consumers' rights, so your commitment to continue to make sure that they have a voice is important. So we'll continue to work with you on that.
Thank you.
Okay. The recommendation is to approve the administration's suggestions and May revision. Is there any dissent? No. Thank you. Oh, I'm sorry, public comment. Here I talk about consumer involvement. I forget public comment. And I would ask the sergeants to help Jeff.
Am I on? Okay.
There you go.
Yes. Mr. Chair and members, we urge the subcommittee to reject the administration's proposal, and we do so for 2 reasons. Firstly, the savings. ask yourselves, will there really be savings when we are contracting with state attorneys to perform a function that non-salaried board members currently perform? If indeed you want savings, I would submit that the department should explore video conferencing and other methods that would be cheaper than doing it under the current mechanism. Secondly, the maxim, if it ain't broke, don't fix it. The Rehabilitation Appeals Board, under no one's view that I have heard up until this time, has not done excellent quality work for the department and for consumers. So what does this board do? This board makes life-altering decisions that can mean the difference between whether individuals with disabilities become tax-paying, independent members of society, or whether they remain on the rolls of those receiving income support and help under an array of public health and social services programs, thus costing the taxpayers of this state tens of thousands of dollars. These individuals have expertise in the area of rehabilitation and employment of persons with disabilities, which cannot be replaced by state ALJs. I would submit to you that because this will save little, if anything, and because the current system works well, let's make it work better if possible, but not abolish it. Thank you very much.
Thank you, Mr. Tom. Any other public comment? Thank you. Well, I think those are good comments. It certainly has given us pause as staff and myself when we've considered this, but having considered the whole environment we're in and trusting the department and knowing we're going to continue to work with them, the motion is as stands. Is there any dissent? All right, that's unanimous. Thank you. We'll look forward to continue to working with you. That will take us to social services. And we have a number of issues in this department. We'll start with opening comments, and then we'll go to issue number 1. All right, welcome.
Thank you. Mr. Chairman, Senator Alquist, Senator Emerson, Will Lightbourne, Department of Social Services. Just want to offer a couple of brief comments before we go into the items, and our division deputies, our program deputy director, Pete Charvinka, and our partners in OSI will be leading our responses. As the Secretary said earlier this morning, most of the items affecting social services programs were actually dealt with in March. Much of what is before you today are either caseload estimation changes or implementing actions based on March. The two exceptions to that are DSS items 1 and 2, which you'll hear momentarily. These are automation projects. While we are of the belief that given the fiscal climate, it is prudent to take the opportunity to examine whether there are more economical approaches available to us at this time, I do want to reiterate the department's strong commitment to the importance of these technology projects, to our partners in the counties, to the service provider network, and the fact that we are engaged in a sort of an ongoing dialogue to try to determine what strategies are available as quickly as possible to avoid any serious loss of functionality or loss of progress. So with those as the introductory comments, I'd just like to say that I look forward to working with you going forward, and ask our first team to come up and join me to respond to, present and respond to you. Thank you.
And while they do that, let us just welcome you. We always welcome, someone used the expression poaching in a previous item. We always welcome poaching people from Senator Alquist's area in Santa Clara County. So get the best and the brightest from Santa Clara sometimes, oftentimes I should say. Sometimes? All the time. That and San Bernardino and Contra Costa County. So issue number 1 for the Department of Social, or in Riverside. Why do I always do that? I think I'm going to have to go visit you. All right, issue number 1 is a Child Welfare Services web project. This is on page 30 and 31 of the packet. Let's hear from the department.
Mr. Chair, Kevin Gaines with the Department of Social Services. The proposal before you is to suspend the CWS web project indefinitely, kind of a step one of a two-step process. And by suspend indefinitely, we mean a halt to the current procurement that is underway. As of the release of the May revision, we were involved in reviewing 3 draft proposals submitted by prospective bidders with the intent of receiving final proposals in November of this year and following with a contract award in fall of 2012. With the termination of that procurement activity, we propose to retain a number of the staff, the state and county staff involved in the project planning phase, to assist the county and assist the county and the state to propose a series of next steps. Largely outlined. I couldn't do it any better in terms of describing it than the staff recommendation before you. Figure out what the current how the current functionality of the legacy system CWS CMS matches the needs of county social workers and state staff. Figure out whether a modified version of a procurement would be necessary, or enhancements to the current system, or perhaps leaving the current maintenance and operations plan as it is, with the practice of periodic adjustments to meet programmatic needs. As far as the questions that you have, whether the analysis has been done to determine whether changes to the system are necessary, we believe that a reduced team of county and state staff together will arrive at a series of recommendations for this committee, hopefully by the May revision. Your second question regarding interaction with the federal government regarding potential changes to the applicable federal requirements. As you've probably heard, the Federal Administration for Children and Families is involved in a redesign of the requirements that we follow, the statewide automated child welfare information system requirements that states who receive that federal funding adhere to. We've gotten no official information as to when that redesign process will be completed, despite weekly phone calls, several interactions with our federal partners. They're pretty well silent on that question. The response we've gotten many times is could be 1 year, could be 10 years. So I think the way going forward, I think, is to perhaps look at the ongoing needs for county social workers, support staff, state staff, research staff involved in making the system run. We would rather focus our efforts on meeting those needs as a primary.
Thank you. LAO, anything?
Good morning, Mr. Chairman, members. Erica Lee with the LAO. Given, as was stated, the potential changes to federal requirements for the child welfare systems, as well as the savings that could be achieved through this proposal, we agree with the proposal.
Okay. Finance, do you want to add something?
Yes, Mr. Chairman. Tom Williams from the Department of Finance. We support the suspension of the project. In regards to the proposed trailer bill, we ask that a change be made in the effective date of that from January 1st to January 10th, 2012. This would align better with the release of the governor's budget, and it also would conform to the action that the Assembly took at their hearing yesterday.
I don't know. We might have several hearings on that. No, it's all right. We can do that. Yes, we'll send that to Conference Committee. All right. Public comment. Mr. Mecca, what do your clients think? Would they perhaps a new system from DMV?
Thank you, Mr. Chairman. Frank Mecca, you had me there. From the County Welfare Directors Association, we support the staff recommendation and are sort of comforted at the fact that the staff recommendation really does comport with the administration's sort of take on what's going to happen during the period of suspension. What I'd like just to underscore is how critical the issue is for getting to the tasks in the language on your agenda quickly. This is the system that workers use to enhance the safety, well-being of abused and neglected children. The legacy system was designed over 20 years ago, and for the last several years, at least, if not more, the state has, probably appropriately, frozen its upkeep from adding sort of significant changes to the system that are needed by social workers. For example, the ability to remotely record your field observations so the worker doesn't have to drive back to the office. There are a number of sort of key things about practice and policy that we as a state decided not to automate in the legacy system because of the expectation that we'd be doing it in the upcoming system. So there's a backlog of some really critical things that we need to get to quickly. And we appreciate the staff recommendation, which sort of allows us to have stakeholder involvement to identify what they are and to figure out how to address them as quickly as possible. The other thing I would say is I'd like to caution the committee, having been around human services automation issues for 2 decades and dealing with the federal government, that we actually listened to what Mr. Gaines said about figuring out what's needed for the programs, what's needed for the workers, more importantly, what's needed for our clients, what's needed to meet legislative expectations. We have to be careful that we don't sort of chase the changing federal verbal